Hello everyone, now we'll discuss about surgical staplers used in the modern surgery. Surgical staplers are highly specialized tools used to close incisions, connect internal organs, resect tissue, increase the speed of the surgery, maintain consistency and reduce contamination. The core components of the cartridge are anvil, knife blade, firing mechanism, safety mechanism, articulation joint and a reload cartridge. The cartridge is the preloaded stapler. Anvil forms the B shape. Knife cuts tissue. Firing drives the staples. The safety prevents misfires. Articulation angles head. Reload matches tissue thickness. The staple geometry. It is made of the titanium or the stainless steel. The legs are bent to B shape. Closed staple height should be more than or equal to the tissue thickness, as small will cause loosening of the staple, as large will be insufficient to cause anastomosis. Staple classification is based on the configuration, mechanism and application of the stapler. The different types of staplers are the linear staplers, that is thoracoabdominal or the thoracolumbar staplers, linear cutting, the gastrointestinal anastomosis or the linear division staplers, the circular, the end-to-end anastomosis and the circular end-to-end anastomosis staplers, the pursue stick staplers, the skin staplers. The image shows linear staplers and the circular stapler images which are used regularly. The linear stapler, it delivers straight lines of staples, often incorporate a knife to complete excision and side-to-side anastomosis simultaneously. Thoracic sealing, transaction of vasculature and gastrointestinal resection are the main modalities. It is used for very straight articulation and side-by-side tissue compression. Circular staplers creates end-to-end anastomosis by forming a circular row of staples while excising excess internal tissue. The colorectal, lower anterior resection, esophagogastric and gastrointestinal surgeries. It is mainly used. The mechanism is detachable anvil, central shift and integrated circular plate for restoring continuity in hollow organs. It is discussed in later slides more detailedly. The color codes of the cartridges for endo or lap cutter: white, which measures less than 1, is mainly for vascular. Blue, which measures 1 to 1.5, is for bowel. Green, which is 1.5 to 2, is also for bowel. Gold, which is 2 to 2.5, is for thicker tissue. Brown, 2.5 to 3.5 mm for fibrous tissue. Black, 2 mm for vascular. Red, 1 to 2 mm is also for vascular. Purple, approximately 1.5 mm is for small vessels. The color codes for the open circular GIA are the blue 1.5 mm bowel, green 1.2 to 2.5 mm colon, white for vascular mesentery. The sizes for the circular end-to-end anastomosis staplers are the 21 mm for narrow esophagus, 25 mm for standard esophagus or colorectal, 28 to 29 also for colorectal, and 31 to 33 for lower anterior resection. The thoracoabdominal stapler, it is a two staggered staple rows, no integrated knife, length is 30 to 90 mm, cartridge is 4.8 mm or the 3.5 mm, is used for bowel, lung and pancreatic tissues resection. The gastrointestinal anastomosis stapler, it has two rows and a knife. The length is 50 to 100 mm. Blue, green and white cartridges are available. The ileal pouch anal anastomosis, Roux-en-Y anastomosis and Whipple's are done by this stapler. The gastrojejunal anastomosis is performed using a cluster stapling device. Circular staple introduction into the enterotomy. It binds the pouch of roux limb. The anvil staples mating to perform end-to-end gastrojejunal anastomosis. Anvil is seated to the nasogastric tube placed by a assistant at the head of the bed. End-to-end anastomosis stapler technique. A persistring suture is applied. The stapler is inserted. An anvil is placed. The gap is closed to gauze. The staples are fired and knife cuts the excess tissue. Remove the stapler counterclockwise. Look for the downward and air leak test needs to be done. The image shows the stapler end-to-end anastomosis, the colorectal anastomosis, the anterior lower resection. The anvil of the EEA stapler is sutured into the proximal colon with a persistring suture. The EEA stapling device is introduced into the rectum. The pin is retracted during placement of the device into the rectum and only extended ones at the staple line. The pin is introduced through the rectal stump and the anvil and pin are mated to approximate the two ends of the anastomosis. The stapler is fired, engaging the stapling and cutting mechanisms. The stapler is withdrawn, leaving an intact colorectal anastomosis. The tissue linear cutter, the cartridge, and has two anvil halves, alignment forks for grip, internal blade between the rows for cutting. Procedure for prolapse and hemorrhoid stapler. It excises rectal mucosa. Staplers of 2 to 4 centimeters above the dentate line. It causes less pain and has a faster recovery rate. Risks are of bleeding, fistula, and recurrence. Endoscopic linear cutter. The port is 12 mm. The shaft is 5 to 12 mm. The articulation is up to 45 degrees. It has strokes of 30 to 60 mm. Powered forms are the Echelon and Signia company. The robotic endowrist is also available. The powered versus the manual. The force is variable for manual and is consistent for the powered. Uneven compression occurs in the manual one and there is uniform compression in the powered one. Tactile feedback can be obtained in the manual. Only visually we can assess for the powered. The chances of misfiring are higher in manual and lower in powered. Manual is less expensive compared to the powered one. Stapling in bariatric surgery. For sleeve gastrectomy, 4 to 6 firings with the golder on the green needs to be done. For Roux-en-Y gastric bypass, gastrointestinal anastomosis with end-to-end anastomosis for pouch of less than 30 ml is to be done. One anastomosis gastric bypass surgeries, they have a long pouch and a single anastomosis is to be done. For biliopancreatic diversion, multiple gastrointestinal anastomosis needs to be done for supermorbid patients. Robotic staplers, end of wrist excise 360-degree articulation is present. 6 reloads per instrument are present. The cartridges are color coded. They have deep pelvic precision. Skin staplers, disposable skin closure device. It has single rectangular staples. It holds skin edges together. It avoids wound edges. There is B-shaped staple formation. Preloaded 35W staples are present. It causes rapid closure of the wound. There is lower infection risk. Produces uniform tension across the wound. It has an angled head which contains 35 staples. It has a firing handle. The staples are rectangle shaped, 7 mm in width and 4.5 mm in height. The intraoperative complications are the misfiring or the incomplete firing, transaction without stapling, tissue tear or fragmentation, structure inclusion, cartridge mismatch, failed doughnut formation, staple line hemorrhage. The postoperative complications are the anastomotic leak, anastomotic stricture, staple line bleed, dehiscence, pancreatic fistula, bronchopleural fistula. Procedure for prolapse and hemorrhoid specific right ventricular failure are noted in less than 0.1% cases. Staple line reinforcement is done by peristrips dry, that is pericardium of the bovine is used. Gore seam guard mesh, collagen strips, oversoon absorbable sutures used in lung, sleeve gastrectomy and pancreatic surgeries. The prevention strategies. The prevention of the complications can be done by using the correct cartridge selection, tension-free anastomosis, preserved blood supply to the anastomotic region, avoid ischemic tissue, leak testing, diversion and drains, buttress materials, and power staplers. Thank you.